Thank you all for coming. Thank you guys for having me. People that are sitting in the back on the floor, especially people in my lab, should come up and sit in the chairs here. No pressure. I'm wearing my, as any of you can tell, and any of you who know me know very well, science and medicine are important to me, not as important as fashion. I'm wearing my white coat here very purposefully for two reasons. The first reason is because I didn't have time to change into my fancy coat when I ran back from a patient just now. And the second reason is to convey intuitively that CyTOF, Cytobank, and Human Immune Monitoring Core facilities are sufficiently user-friendly that even a doctor could be able to utilize them to help our patients, to understand what's happening with our patients better, and to help devise next iterations for how we're going to help our patients even better still. So this is a talk a little bit at the interface of science and medicine, hopefully. The catchy title, if you felt that it was catchy, then you were right to feel that way, because it is Turning a Tumor into a Vaccine Manufacturing Facility. Those of you who work in this building know that we are developing, Nina Bardwaj and Rachel Sabato are developing a GMP vaccine manufacturing facility on the 6th floor, which is extremely fancy and fantastic. In parallel, we are working on a way with our patients, particularly patients with lymphoma, to, for the time being, bypass the need for a GMP facility and actually make vaccines in patients' tumors. So that's why we call it an in situ vaccination. We are making a vaccine at the site of a tumor using some tricks that we developed at Stanford and some new tricks that we're developing here at Mount Sinai. You really can sit in the front. There's a lot of seats if your butts gets tired. Okay. So there are some scientists in the room, some doctors in the room. Some of you know this. I'll point it out because it's relevant for the science we'll talk about in a minute. We're going to study here mostly low-grade lymphomas. Lymphoma is the 5th most common cancer in America, so it's less famous than the big four, but still a very common problem from which people are suffering and from which people are dying. So we need to do better in treating these people. Most lymphomas derive from B cells. We have rare subset we call Hodgkin's lymphoma. Dexter from the TV show Dexter has Hodgkin's lymphoma, not in the show, but in real life, Michael Hall. I have celebrities for every one of these blue boxes here. I'm not going to go through each of them, but it's very important when you need funding to know which other celebrities that have these things. So most of the lymphomas are not Hodgkin's lymphomas. The majority of those are derived from mature B cells, and the most prevalent amongst those are what we call low-grade lymphomas. These are the 3 most common subtypes of low-grade lymphoma that we see in our patients. Low-grade lymphomas have good and bad news associated with them. They are good in that they do not kill you right away, and we have some good therapies to treat those diseases. And the bad news is that they are incurable with standard therapy, so we need novel therapies. We need safe, tolerable therapies, because many of the therapies we use are not gentle on our patients. And we need mechanistically distinct therapies. So immunotherapy rises to the top in all 3 of those, by all 3 of those parameters. So these, again, are all derived from mature B cells, which becomes relevant in a bit. Just to reiterate that sort of good and bad news of lymphoma, the good news is we have standard therapies which work for the majority of our patients the first time we use them, with a vast majority of patients having a clinical response, meaning that their cancer shrinks significantly. And those remissions can last for months or even years. So that's the good news. The bad news is that they universally recur. The disease universally recurs. And when it recurs, the reiterative use, that's a tough adverb, reiterative use of that same therapy works less well each time, or those same or similar therapies work less well each time, and those remissions are of shorter duration. And eventually, virtually for all patients, we end up at a point where the patients are refractory to standard therapies. And what we told them in the beginning was not such a bad disease because we have some good treatments, becomes a very emotionally exhausting thing over here on this side, because now we don't have good things to treat our patients, and patients are dying from even these low-grade lymphomas every year. So we need to do better. This is one approach we developed back at Stanford to try to do better. Again, we developed this just downstairs from Gary Nolan. So, I mean, it's 50 yards, really. It's very close. In some way, he was the inspiration for all of this. You try to buddy up to any celebrity you know. So the idea here was that, as I say, these lymphomas are derived from mature B cells and maintain much of that mature B cell program, including the expression of certain toll-like receptors that are canonically expressed on B cells, TLR9 the most famous amongst these. So by co-localizing a TLR9 agonist, CpG is a little synthetic stretch, an oligodeoxynucleotide that looks like bacterial DNA to our immune system by virtue of binding to TLR9. We can turn even those lymphoma cells themselves into antigen-presenting cells, and of course, and activate them to a degree. And of course, we can also activate the most famous antigen-presenting cells, dendritic cells, to be more active. Unfortunately, in the tumors, we have very few of these professional antigen-presenting cells, these dendritic cells, but we have a great number of what we sometimes call these amateur antigen-presenting cells. So our idea here was sort of a crowdsourcing idea that even with an amateur, if we have billions of them, maybe we can effectively present antigen to these anti-tumor T cells that on then seeing their presented antigen can become activated, and we read out activation by reading surface markers on those T cells and also by cytokines that they excrete. This is the concept. The way we can actually test this in our patients is to treat one site with intratumoral injections of that TLR9 agonist. And right before we do that, we give what we call mini-dose radiotherapy. So it's about a 20th or a 10th of standard dose radiotherapy. So it's fairly simple and safe, but its purpose is to just kill a few lymphoma cells to have some tumor-associated antigens floating around for presentation. So mini-dose radiotherapy, intratumoral CPG, and then this tumor will melt frequently even from that low-dose radiation therapy, but to assess if we're inducing systemic anti-tumor immunity, we measure shrinkage of far away untreated spots, untreated tumors, and their regressions would suggest systemic anti-tumor immune effects. And they would suggest that. They don't mean that, but they at least would suggest it. So this is the concept. This is how we're going to test if the concept works. And the obvious first question is, can it work? And the answer is it can. These are tumor regressions, including, we say, complete and partial remissions in some of our patients, some other patients that benefited somewhat, and then other patients that did not benefit at all, and their tumors continued to grow despite this vaccine, this in situ vaccine. So just a couple of pictures of that. This is actually a sort of a rare variant of lymphoma where it's right under the skin instead of in normal lymph nodes. This is subcutaneous lymphoma right above a right eyebrow. We injected intratumoral CPG into another site near the patient's chest. We see that subcutaneous lymphoma deposit melts away. A somewhat more medically important example, this is a CAT scan cutting the patient across the middle. The patient was not harmed. We don't actually cut, the patient across the middle. There were some people that raised their hands as soon as I say that, so the patient's okay. We just virtually cut them across the middle. And we see here the back of the patient, the belly button, the liver, the kidneys, and a giant lump that should not be there. And the obvious hint of why it shouldn't be there is because there's a green circle around it, which you should never have in any of us. And it is a big lymphomatous mass, a retroperitoneal adenopathy. If it gets much bigger, it's going to squish the outflow tract of this left kidney and create a problem. This patient was vaccinated in the left inguinal site near the left groin and had great regression of that disease. See a tiny lump left over here, so not a complete response, but a partial remission. And along with that, induction of what we call anti-tumor T cells. I won't explain this assay too much, but briefly we co-culture patients' T cells before or after vaccine with autologous tumor, and we see that now seeing autologous tumor in vitro, they secrete more interferon gamma or express more activation markers like CD137 on their surface. So induction of anti-tumor T cells along with clinical remissions. So we think those T cells are the cause of that anti-tumor effect. I'm going to just reiterate this point one more time, that this problem, this very fundamental problem of all of oncology, is what we call diminishing returns, that therapies are less effective with each time. And I mention it again because we have an opportunity, hopefully, with immunotherapy like vaccines to try to change this paradigm. We, as you all know, get measles, mumps, rubella, hepatitis B vaccines at a time point, and then we get a booster vaccine 6 months later, because the immune system, like the nervous system, has memory, and a memory immune response is of greater magnitude than a primary immune response, and also more rapid. So we would think that perhaps a booster vaccination of these patients, if they were to need it, could induce a greater magnitude and more rapid immune response. In this first group of patients, I showed you the results from 15 patients. We treated 60 patients in total, some of them with very long remissions, even lasting years. We had one of those patients who had a good remission. This is actually the same one I showed you before. Her disease recurred about 1.5 years later. So now she has, we say, cervical adenopathy. So this is cut across the top of the chest here, the windpipe, the back of the neck, the clavicle, and this is her right internal jugular vein, and this lymphomatous tumor is about to squish that if it gets much bigger, which would not be good. We have, again, a recurrence of this retroperitoneal adenopathy, which, again, could impinge on the kidney outflow tract. So this patient got another vaccine now to the site in the right groin and had, again, great regression of those sites of disease that are far away from the injected site. And what you can see from these pictures is that the total magnitude of this response was greater than her primary vaccine, and the rapidity was greater than with her first vaccination. So it is just an anecdote towards that concept of breaking the paradigm of diminishing returns and actually getting augmenting returns with reiterative use, and we need to do more of that with our ongoing work. So the ongoing work, here at Mount Sinai, we wanted to try to, if we could, get away from this amateur antigen-presenting cell and get to this professional antigen-presenting cell. This cell, the dendritic cell, won a Nobel Prize in 2011, so we know it must be a good cell. And it actually shared that Nobel Prize with the toll-like receptors that these cells express on their surface between Doctors Steinman and Hoffman and Butler. So we literally now walk to our patients and say, we're going to inject little Nobel Prizes into your tumor, and that's how you know. And then they flock to that concept. I mean, it's the next best thing to knowing a celebrity is having a Nobel Prize. So it's still pretty good. And so we wanted to do that from the beginning, didn't really have a clinically feasible, practical way to do that. And now, for practical reasons, we do. We have access to a clinical grade recombinant molecule, Fit3L. Fit3L, when I explain this to our patients, I call this the erythropoietin of dendritic cells. This is the primary growth and differentiation factor of dendritic cell precursors. It actually also binds the dendritic cells as well, who even mature dendritic cells express some FLT3 as well. So we could now, very similar concept, by putting FLT3L to the tumor site, can recruit more dendritic cells by co-localizing a different TLR agonist, in this case a TLR3 agonist called Poly-IC. We can activate those dendritic cells. And now the concept here is with the professional antigen-presenting cell, we can really activate these rare anti-tumor T cells to become powerfully activated, to proliferate and go induce systemic anti-tumor immunity. So that's the concept. Again, we will ask the question in a similar way, just a little bit of preclinical data to sort of get our foot in the door and make the point that this is an active molecule, FLT3L, injected intratumorally into a mouse lymphoma model. Looking in that tumor, we see several-fold increase in intratumoral dendritic cells, even more so than if we inject that FLT3 systemically. And depending on where we put these gates, it could be a many-fold increase compared to the basal state. We actually see an increase in T cells as well, and I don't understand that yet. We have to learn what the mechanism of that is as well. So just a proof of concept in the lab, and this work is ongoing with one of the postdocs in my lab, Dr. Hemmerich, who is doing this in a much more elegant way now. And to give a hint at later stuff, taking this beyond flow cytometry to the next thing. So again, this is the concept. We ask this question the same way in our patients, treating one site, but here with a 2-week priming phase of intratumoral FLT3 ligand, followed by low-dose radiotherapy, and then intratumoral TLR agonist injection. So these are all the cartoons to tell you what I want you to think happens, but we actually get some chance to actually see what really happens. So I'm going to show flow cytometry data, and I'm going to hint at why this trial started about a year ago now. We filed an IND with the FDA a year ago now. We were lucky that the FDA approved it without any delays, and we started treating patients at the beginning of this year before we had as easy access to our CyTOF. So what I'm going to show you is flow data, and I'm going to give some obvious reasons why we are now trying to move this beyond flow. The most obvious reason is what we're going to look at here is actual, of our patients, intratumoral sampling, so fine needle aspirates that we were doing of our patients during their therapy, before and after each part of their therapy. Sounds scientifically simple, but if you're the patient getting a giant needle jabbed into your neck repeatedly, first of all, you would want it to get, you would want less jabbing, number one. This is one of our patients' requests. If we can do the same thing, less jabbing, then we think that would be even better. And then more importantly for us, we want to literally get the most out of every jab. So I'm going to show you that we needed to at least get this information out of here. We kind of come to the correlative aspect of this clinical trial with very directed questions, but at the end I'm going to explain why we need to open up those questions to really juice this information. as the Native American does with the buffalo. Okay, I'm going to come up with a better metaphor when we redo this talk next time. I mean, I like it, but it's kind of out of nowhere. So I got to think of a celebrity there. Okay, so this is looking at the patient's tumor, and these are two different dendritic cell markers defining what we call BDCA1 dendritic cells and BDCA3 dendritic cells. Very few dendritic cells in a lymphomatous tumor prior to therapy. After FLT3 ligand therapy for 9 days, a mild increase in these BDCA3 dendritic cells and a marked increase. This is really probably 0.01 actually, so we see somewhere between 10 and 200 and 600-fold increases in intratumoral BDCA1 dendritic cells, so a potent effect. And really, again, this was our very focused question to prove that we are accomplishing what the cartoons insist we are accomplishing. And then 2 weeks later, after radiotherapy and poly-IC, some persistence of these BDCA3 dendritic cells, very few of these BDCA1s, we think that they traffic to secondary lymphoid tissue. One more point to make about the cells coming to the tumor, looking at their activation state, CD80 as an activation marker, and PD-L1 downregulation as a sign of myeloid cell activation. So very few activated dendritic cells prior to therapy, a mild change after FLT3 ligand therapy, and then a marked, maybe 10-fold change in activation of these myeloid APCs after intratumoral TLR agonist. So marked activation of the immune system here, specifically of these APCs at the tumor site. By contrast, if we look in the blood, look peripherally in the blood at the same time, we are not activating the immune system systemically. This is appealing to us. We have actually now, and we're very lucky in oncology to have a few anti-cancer immunotherapies that are encouraging and sometimes effective. Some of them have risks of inducing anti-self immunity, autoimmunity, and our concept at least here is to try to focus the immune system on the tumor and hopefully focus the immune response there to tumor-associated antigens as opposed to peripheral antigens. So nice to see that with that approach we can activate dendritic cells at the site, not in the blood. We also, in many ways, and I have to thank Sunji and the whole Human Immune Monitoring Corps for all this data because they generated it and because they were nice about it and extremely user-friendly, and point out here that there are reams of data, which I'm not showing you, which the HIMC helped us to develop, and I will describe one little bit of it that we are also at the tumor site switching T-cell phenotypes from what we call central memory to effector memory, which we think is important in inducing the anti-tumor immune response. And we have many activation markers on these T cells showing that they are becoming activated as read out in many different ways as well, and I won't show that data now. Jumping to the, I guess it's cutting to the chase. I don't know, maybe jumping to the, I'm not sure if you can jump to the chase. You can only cut to the chase. Jumping to the punchline. These are our clinical responses from the first couple of patients. We've actually just finished treating the first 4 patients now, but the last couple were just in the last week, so I don't have their data up here yet. But these are the black lines, tumor regressions in the first couple of patients just over the first 6 months. Both of these patients had responses. Actually, an update is that this patient number 2 now has a complete response or is in complete remission. Patient number 1 here got a partial response. Patient number 1, who is the squares, also had resolution of low red blood cells and low platelets, which were being caused by his bone marrow being packed full of lymphoma. And just as his bone marrow was packed full of, I'll show one picture of that. Just as his bone marrow was packed with lymphoma, he also had lymphoma in his peripheral blood, and we'll look at his peripheral blood response in a couple of slides. Just to show a picture of giant tumors melting away, far away from the injected site. So this was one of those first couple of patients. We are injecting all of those things into a left inguinal node near his leg. This is looking at his neck, cut, we say coronally, or cut transversely. We are none of us in the room radiologists. Christian, you're not a radiologist, right? No, I wasn't sure what you were, but okay. I saw one other white jacket, but none of us are radiologists. But even all of we know that people should be symmetrical in most ways. If they have a jugular vein on their left side, they should have one on the right side. But this person doesn't because this bulky neck tumor is obstructing his jugular vein so much. You can actually see it even here on cross-section, that where you should have these open circles of blood vessels, he's got these squished little circles here. So this was prior to vaccination. We injected into his left inguinal site, and now we have at the neck here drastic reduction of this cervical lymph node of this tumor, as you see again here on transverse slice, And looking here at the very top of his pelvis, the very top of his hip bones, these are called external iliac lymph nodes, melting away again after vaccination. So big tumors melting away, which is very gratifying for us, but especially for this patient. You could even see here, even from this CAT scan, that when you looked across the room at this patient, you could see he had big tumors sticking out of his face, and you can see here that now he has a smooth face. So he was gratified. We were very happy. This is my favorite slide in the talk. Sorry, CytoBank, I'm sorry, CyTOF, because this is flow, and yet this is my favorite slide. So much so that it has become the backdrop for my phone now, and I replaced my niece and nephews to put this slide there. So what we're seeing here is that looking in this patient's blood, CD19, a B-cell marker, these are B-cell tumors. So these are almost entire, these are 99+% tumor cells in his blood. And we all have 3 times as many T cells as B cells in our blood. This patient has more tumor cells than T cells in his blood. Prior to vaccination, after vaccination, an 8-fold reduction. Months after the vaccine is completed, that tumor load still going down, so more than an order of magnitude altogether. It's actually more than that when we look at a more intelligent denominator. But still, while these malignant B cells are going down, we have many ways of treating lymphomatous B cells. As I said in the beginning, we have chemotherapy, but many of those standard ways, like chemotherapy, kill B cells and kill T cells at the same time. So we somehow here are killing malignant B cells while T cells are actually increasing in the blood. So somewhat specific. And we, with lymphoma, have a very lucky trick that we can use to ask an even more specific question. Lymphomas are all B cells. They are all derived from a clone, so we say they are light chain restricted. This patient has a kappa light chain restricted tumor, so they are all lambda light chain negative. So we see that almost all of his B cells are his malignant clone. A tiny fraction, maybe 1/100th of them, are healthy B cells that are lambda expressing. And as we are killing malignant B cells, and we again have other ways of even killing just malignant B cells in lymphoma. We have rituximab and other antibodies that target B cell antigens, but they kill malignant B cells and healthy B cells at the same time. Somehow, by contrast, here we are killing malignant B cells while healthy B cells are actually increasing in number at the same time. We believe that somehow we are targeting tumor-associated or tumor-specific antigens that are on the tumor B cell, on the malignant B cell, and not on the healthy B cells. And we're going to try to prove that point. Again, as I said with flow, and I'm going to go quickly here for the sake of time, just a couple more slides. Again, our first purpose with flow is to kind of prove that what we are saying should happen at least does happen. If we did not recruit dendritic cells to the site, it would be hard justified to say, oh, we are going to continue on for another 30 patients and do the same if we're not at least achieving what we call that pharmacodynamic endpoint of doing what the medicine is supposed to do. So that we had a very directed purpose. Now that we have patients that are responding, and from showing the first 2 patients, I would fool you into thinking it's 100% of patients who respond. Now it's 50%. We have 2 out of our first 4 patients responding, a complete remission, partial remission, and 2 patients with stable disease. So we have some patients that respond, some that do not. Any scientist, doctor, or even our patients ask us the obvious question: why did this guy respond and why did this guy not respond? And we don't know the answer, but we have an opportunity to get that answer, and that is with the immune repertoire profiling we do both in the blood and in the patient's tumor as we go. So we feel obliged now to dig as deep as possible. There's a pun here. Okay, there's a picture of a spade. There we go. Okay. And that is our purpose here, is that we have a unique resource. This trial is happening at Mount Sinai, nowhere else in the world, to my knowledge, the universe, as far as I know, and we have these samples that we have access to. These samples are rare and precious and irreplaceable. We want to get the most as we can out of every sample. So this is just looking at one of the next patients, patient number 3, prior to Fit3L therapy. I have to thank Adib for incredible amounts of help here because although I forced everyone in my lab to use CytoBank, I'm still not very spade proficient yet. So thank you to Adib. Just looking at some of the numbers, you will have to memorize them for the moment because I'm going to overlay the next numbers. Looking at the cells we were focusing on, the CD1, see these BDCA1 dendritic cells, again, we see them increasing tenfold in order of magnitude. These rare dendritic cells increasing also about 20-fold in order of magnitude. And some and plasmacytoid DCs increasing as well. So none of that surprising, reiterating something we already saw, but things we would never have guessed, or I would never have guessed, Basophils are increasing. I think it's an order of magnitude. I don't have the numbers here. And we have these other populations of some type of CD14 high monocyte, a specific subset thereof, who are probably increasing by an order of magnitude as well. So we have to go back and now try to understand that better. And our purpose here will again be to take as many of these parameters as possible and generate hypotheses between different patients, why some respond and some don't. At least between looking at a couple of these patients, using our pun, we have this next patient where we observe again some of the same observations, slightly different, but some CD14 high monocyte populations that we did not know enough to think enough to ask about by flow, but that are changing drastically. And some of these we could probably hand wave and say maybe there's some mouse data showing that these cells express Fit3L as well. And basophils, there may be a bit of data towards that, although not really. So these are kind of novel discoveries for us. And these might be the things that are correlating with clinical response. So we need to get every bit of information we can out of here. I'm going to put just 2 more slides here to show. This is all about how a fancy trial of a novel therapy can exploit CyTOF and cytobank, hopefully to make the trial achieve its utmost. This is something that is more along the lines of what every oncologist or maybe every doctor in this medical system can do, which is how we can look at the immune repertoire effects of standard therapies. To any doctor in the audience, this font is very powerful. As some of you know, New England Journal of Medicine purchased its own proprietary font, which is different than Calibri, it's different than Arial. Our eyeballs and our cerebellums respond very viscerally to this font because we don't have science in nature, we have this. So this font is powerful, and you will very rarely, or I'm going to say just about never, see the same medicine showing up in this font 3 times in a year or ever. So this is a big deal. This is a BTK inhibitor that has revolutionized some parts of lymphoma therapy. In addition to killing cancer, it also, in addition to hitting BTK, also hits ITK, which is in T cells, and thereby has a powerful skewing effect on the T cell repertoire, probably in other parts of the immune system too. So we see Th1 skewing and also some CD8 skewing secondarily as part of this therapy being given to kill cancer. We almost have one other example of the same font for three of the same, but it's just 3 of the same pathway this year. So what I just showed was the biggest thing in lymphoma this year. This is by far the biggest thing in oncology this year, which is, again, as I hinted before, anti-tumor immunotherapy, all focused around the PD-1 pathway. So this is not us using any fancy clinical trial samples. This is using regular blood from one of our patients, and I'm just going to show the pre, and I'm not going to show any post, because that's all still cooking, and hopefully Adib will still be as plug-and-play as he has always been for us. This is just looking at, again, I mentioned Th1 skewing as a result of ibrutinib therapy. That group, which is a great group in Ohio, didn't have the chance to ask a more rigorous T-cell repertoire subpopulation question, but this is how we're going to be asking that question. We're going to look at Th1 and many other T-cell subtypes because ITK is expressed in many T-cells and could have profound effects, and we're going to ask it specifically with the question of how much PD-1 is expressed on each of these subsets during ibrutinib therapy, with the obvious future aim of saying to the PD-1 companies and the ibrutinib company, hey, can we do a trial of ibrutinib and anti-PD-1 therapy? And when we show them these pictures, they say, oh, you guys have one of those. And that makes them think that we are a real place, which we are, but now they know it. And so that is a very practical way in which this has been helpful for us. I have to thank all of my collaborators. Adib, I kind of had to magnify your head a little bit. I hope it still looks good. And I have to thank everyone. If there's time for questions, I'd be delighted to answer some questions.
Did you also look at the anti-tumor antibody response?
In the mouse model, it's all about CD8 cells, and in some of the other mouse models, CD4 cells, and not so much about B cells. A B-cell deficient mouse in that first model does just as well. In our first group of patients, those first 60 patients we tried, we didn't see obvious correlation. We didn't see obvious antibody responses. And in this new group, we have not looked yet. Good question. Thank you. Hi.
That's really cool work, Jeff.
Thank you.
And, you know, Gary Nolan, celebrity or not, I think Ron Levy gets some credit.
Yeah, he's
right?
like whatever.
Let's not forget.
He's a guy.
He's a great guy. So I was curious, in the patients where you saw an initial response and then the tumor relapsed after your immunization, do you have any clue whether that's because they are essentially escaping immune pressure and it's just coming back without those antigens that the immune system was putting pressure on, or is the immune memory going away and you basically just need a booster vaccine against the same antigens?
I will give you a depressing and an uplifting answer. The depressing answer is I have no clue which of those two it is. Those are sort of the two hypotheses that we are working with. Immunoediting and antigen escape versus exhaustion. The way we do our boost, we would sort of be able to take, so if we boost and it works again, it won't even mean it was the second one, because when we boost, we're going to go back to a new tumor which could have those escape antigens as well, or that new antigen repertoire. But what will allow us, so that's all the depressing part. Uplifting, when these patients come onto these studies, we have a little bit of leverage, and we get a biopsy of their tumor, and a big biopsy, and we can do a lot of things with it. And the things we are doing now are both RNA-seq and whole exome sequencing of, again, that first tumor, and then when we retreat them, of that second tumor. So if I get all of my genomics colleagues to explain those super confusing algorithms to me, then I'll be able to answer your question in a year, hopefully. That's a big if, because when they tried to explain them to me the first time, I was a little confused. But I hope that we will have a better answer for you in the near term, because we already, on this new trial, starting to look at the opportunity to boost some of those patients and then get a secondary sample from them. Thank you. Guys, thank you so much.